Good afternoon. Thank you for taking your time from your busy schedules to join us for the webinar, Concussions at Summer Camp. This webinar is being hosted by the Center for Injury Research and Prevention at the Children's Hospital of Philadelphia. There we go. My name is Suzanne Hill. I'm Associate Director for Advocacy and Outreach at the Center for Injury Research and Prevention. Our goal today is to address the concerns summer camp nurses have about managing recovery from concussion while a child with a concussion remains at camp. We'll do this by sharing state-of-the-science strategies with a goal to improve your skills and increase your confidence. I'm very happy to be moderating this important session. Recently, our research team here at CHOP published a study that showed that the activities children engage in on a daily basis can result in concussions. While the majority of concussions are related to sports and recreational activities, 70%, only 40% of all concussions are from contact sports. In fact, the combination of gym class, recess, playground, all similar activities represents the fourth most common sports and recreation-related activity, following football, soccer, and basketball, and ahead of ice hockey. So I think no matter the type of summer camp you support, the potential for a concussion injury is present. With the help from today's speakers, we hope you'll feel better prepared to manage the process of recovery for youth with a concussion as we head into the summer camp season. Before I introduce our speakers, I'd like to address a few housekeeping items. First, if you're having technical difficulties, please reread your confirmation emails. The latest one was sent at 10 a.m. this morning. In the emails, you'll find links to join the meeting and to download WebEx Event Manager for first-time users. You should hear the audio through your computer's speakers. There is no call-in phone number for the audio. At this point, unfortunately, we aren't going to be able to help you with the technical issues. If you have questions for the presenters as we go along, please type them into the chat text box in the bottom of your screen and direct them to our host, Lindsay Mitros. There will be opportunities to ask questions throughout the presentation, as well as time designated for Q&A at the conclusion of the webinar. Because of the large group, it's not possible to open up the lines for audio questions from participants, but we will gather and synthesize questions from the group, and I'll ask the presenters at several points along the way. We've set it up so that other participants will not be able to view the questions or comments you submit. From previous webinar feedback, we've learned this can be very distracting. Last housekeeping item, this webinar is being recorded and will be posted at our website, injury.research.chop.edu next week. We'll email you the link. I want to thank Tracy Gaslin from the Association of Camp Nursing for promoting this webinar to her members. We have more than 130 people registered for today's webinar, speaking to the strong interest and concern in managing concussions at summer camp. Among participants, we have many states represented, from New England to Texas, from the Pacific Northwest to the Midwest, from California to Ontario, Canada. Welcome to you all. Now it's time to introduce our speakers. Dr. Daniel Corwin is a pediatric emergency medicine attending physician here at CHOP and an associate fellow in the Center for Injury Research and Prevention, and specifically a member of our Minds Matter Concussion Care for Kids research team. Ronnie Robinson is also a member of our Minds Matter Concussion Care for Kids team and an associate fellow here in CERP. She is a nurse practitioner in the Division of Orthopedics at CHOP. I will now turn the mic over to Dan, who will review our learning objectives.
Thank you so much, Suzanne. And I would just again encourage everyone, as questions come up throughout the presentation, to type in your questions in the chat box. We have a couple of points throughout our talk where we're going to stop to address questions. And we also have a couple of points where we have poll questions specifically for you. So we'd encourage everyone to answer those, as we want to make this as interactive as possible. So you see on the slide here our 4 objectives for the next hour. So we'll start by, in the next hour, we hope you all are able to describe the current practice and barriers in managing concussion in the camp setting. So our information from this comes from a study that we conducted this past summer, and it was conducted in collaboration with the Association of Camp Nursing. So a very big thank you to all of those listening who participated in this survey study. We ended up enrolling 108 camp providers, which included doctors, nurse practitioners, nurses, EMTs, and trainers. And we asked questions regarding comfort and management strategies in the summer camp setting. Overall, we found that less than 50%, actually 49% of our group was comfortable in treating concussion in the camp setting. When we asked about initial management strategy, we found that 44% of our group would either send a child directly home or send them immediately to a hospital or emergency room following a concussion. Of those who would let children rest and recover in the camp setting, about a third of them would require children to be completely absolved from any activity until their symptoms were completely resolved. And then finally, we asked how likely providers were to use a standardized concussion guideline, and we found that 85% were either somewhat or very likely to use a standardized guideline in their camp setting. And that was the impetus for our talk today, and that we hope to be able to address some of the conclusions we have from the study, which is discomfort in managing concussion, some practices that may ultimately be unnecessarily conservative or result in the overutilization of healthcare resources, and perhaps lead to overresting and even prolonged recovery of children. So we're at our first poll question. So I would encourage everyone to click on an answer to the questions that you'll see pop up. So this question is, most often, how do parents of campers react when they hear their child has a concussion? So we'll give you about a minute to answer these, and then I will review the results of the question with everyone. And our poll just opened, so we'll give you a minute or so to answer this. Okay, great. Thank you for everyone who answered that. So interestingly, 44% said parents would like their children to be evaluated in an emergency department. And then our second highest response was see if and how their child can remain at camp. And as we were finishing up the survey study, this is one of the things that we surmised was part of the etiology of kids returning home or going to a hospital was parents wanting their kids evaluated where the provider might have thought they could remain at camp. So another part of our goal, both today and moving forward, is to try to increase our education in just the general community about care after a concussion and what's safe to do following a concussion and what needs to happen following a concussion. So I'm going to turn it over to Ronnie now.
Thanks, Dan. That was a great start. Okay, so the next thing we're going to go over is talking about concussion definitions and why we see some of the symptoms that we see when kids have a concussion. So what is a concussion? I think this is some of the questions I get all the time when I'm doing my job every day. So if you Google concussion, you will find that there's about 42 working definitions of concussion, and most of them are not evidence-based. They're actually consensus-based, which means that a group of experts in the field of concussion get together and decide what the standards are going to be or what that particular definition will be. But really, in real life, we don't define concussion neurologically, and we really don't understand the natural history of concussion, and we really have little data about the neurological or neurobiological recovery after a concussion. And so I love this definition about concussion, which comes from the Concussion in Sport group. So every 4 years, the experts in the world get together and talk about the standards of care regarding concussion in sport. And they most recently met in the end of 2016, and then they published their most recent guidelines in February of 2017. And so what they say about concussion is that it's this evolving injury, which to me means that symptoms can get worse before they get better. It has rapidly changing clinical signs and symptoms, and it's one of the most complex injuries in sports medicine to diagnose, to assess, and to manage. They go on to say that there's often no loss of consciousness, and there's no perfect diagnostic test or marker that clinicians can use for immediate diagnosis. So when you read this, I mean, no wonder that there's so many questions about how to diagnose, how to manage, and how to treat concussions. So we certainly have our work cut out for us. And I actually thought of the 43rd definition of concussion, and really this is kind of what I think about concussions and the definition for me. And I say that concussion is a change in the way that the brain functions. It's following a force to the head or the body. You can have temporary loss of consciousness, but most people don't. We can identify it in awake individuals by measuring different neurologic and cognitive functions. Symptoms can worsen with increased metabolic demands, but the good thing is that symptoms can improve with rest. And most people recover pretty quickly, which we'll talk about recovery timeline in a little bit, but some don't. And so the next thing we talk about is the pathophysiology and what's really happening inside the brain when you actually have a concussion. And so initially you'll see that there's some type of impact either to the head or the body that causes the brain to shake inside the skull. And then changes happen at the cellular level that provoke the onset of symptoms. Normally symptoms happen right away, but the other thing that's important with this is that symptoms happen every time you increase the demands of the brain. So that means if you go to math class and you take a test, or if you're at soccer practice and you're running down the field, or if you're at a campfire sing-along and there's lots of loud noises and bright lights, those things can then provoke symptoms. And so there's a couple of things that are interesting that happen at this point in your brain, and I kind of geek out a little bit when I talk about this, but so the pathophysiology goes like this, that there's this impact to the brain, and at that time there's this sudden or rapid depolarization of the cells, and you have this shearing or stretching of neurons or axons inside the brain. And when that happens, you have potassium that leaves the cell, and calcium rushes in. And this is important for a couple reasons. One is that calcium floods the mitochondria. And what do the mitochondria do in our body? But they make energy, right? They make ATP. So that's why so many kids just want to sleep after they have a concussion, because their body is just not making enough energy. But the other thing that happens is that there are changes in cerebral blood flow after you have this injury. So one is that calcium decreases cerebral blood flow. So when you have this concussion, your brain makes you think that you fell off a roof, or that you went through a windshield and had a more severe TBI, and it decreases blood flow to the brain in order to prevent cerebral edema. That's one of the smart things that our body does. The other thing that happens is that cerebral blood flow is uncoupled with cerebral metabolism. So what does that mean? So when we have something big going on in our lives, like we are going to the prom or we're taking our SATs, then there's an increase in metabolic demand that happens. And then you have a match or coupling of blood flow that happens to meet that metabolic demand. However, when you have a concussion, you don't have that blood flow that's meeting that metabolic demand. So there's this big demand for energy, which is this brain injury, but there's just not enough cerebral blood flow. So that's when you have the supply and demand mismatch, where you have an energy failure. And so the way that we look at symptoms, and the reason why you get symptoms, is because of this energy failure that's going on. And so we have actually put our various symptoms into these 4 categories. So we often see that symptoms are either autonomic in nature, vestibular and ocular motor, mood-related, or cognitive-related. So let's talk about it a little bit. So the autonomic nervous system is in charge of things that we can't control. So when I stand up quickly, my internal blood pressure is regulated. I don't get lightheaded or dizzy because my autonomic nervous system is functioning efficiently. When I walk into a bright room, my pupils get small automatically to block out the bright light to my brain. But when you have a concussion, that system is not working efficiently. So we see light sensitivity, we see sound sensitivity. There's a lot of sleep disturbances that happen with concussion, and all of those symptoms can cause headaches. We also see changes in the vestibular and ocular motor function of the brain. So there's emerging evidence in the literature now that suggests that the vision system, the vestibular and ocular motor system are injured after concussion. And when that happens, kids can't track well, they can't read well. It makes them have a hard time to remember what they're trying to read. They can't take notes in school, and then they get headaches because of trying to do these tasks. The next one we'll talk about is mood, and I'll talk a little bit about this later in the webinar, but I will say that there are chemical changes that happen inside your brain that cause emotional ability, more sleep disturbances, anxiety, lack of impulse control, and we see that often with concussion, so something normal and typical that we see. And lastly, there are cognitive changes that happen. So those that have been taking care of concussions for a while know this to be true. We know there are cognitive deficits in concussion. These are one of the things that we test all the time. Kids have a hard time maintaining the stamina that they had before their injury. They have this lack of stamina. So they have poor memory. They can't pay attention for long periods of time. They have a hard time concentrating, which then causes headache and mental fogginess. And so when we evaluate a patient, one of the things that we're looking for is looking at these 4 different categories. We're doing a vestibular and ocular motor exam. We're taking a history to find out the symptoms that they are having. And from that, we can create a management plan based on the findings that we see. And so diagnosis for me is almost as simple as saying that you have some type of injury or event that causes the brain to shake inside your skull, and then you have symptoms afterwards. The thing that's plus or minus is vestibular deficits. So we know that about 70% of the patients that we care for actually have some type of vestibular or ocular motor deficits on physical exam, but not all of them do. And so I always say that we should have a low threshold of suspicion for concussion, but not every head injury is a concussion for sure. And so we want to make sure that we have the right patient, the right diagnosis, the right treatment at the right time. We don't want to diagnose everybody with a concussion just for a minor head injury. Okay, so actually this now comes up to our next polling question. And so again, we're going to poll the audience, and I'll give you about a minute to quickly respond to that. And so really, we want to know, what is your main concern with monitoring a youth's recovery from concussion at camp? Okay, great. Thanks so much for taking the time to answer that question. So it looks like that there's almost a tie actually between feeling nervous that there's something worse than a concussion going on, and that the campers that you see might underestimate or understate their symptoms just so that they can get back to activity. And I think, those are things that we're always thinking about every day too. I mean, those are concerns that we have. But my goal is, and Dan and I's goal after you attending this webinar and that you get this information, is that you will have more tools in your tool basket to be able to assess when there's something more going on than just a concussion, and really kind of getting a good idea of what's going on with your camper as well, and you can get a good idea of what symptoms they're having and what they can and can't tolerate. I'm going to hand the mic back over to Dan now.
Great, thank you, Ronnie. So a great introduction to what's causing a concussion, and now we're going to dive into what we think may be the most important part of what we're going to talk about today, and that's discussing rest and rehabilitation for concussed youth in the camp setting. So when we look about how we have changed our management of concussion over the last couple of decades, picture a pendulum that has really done like a 180-degree turn. So for me, when I was growing up, and I'm sure this applies to a lot of you, when you had a head injury, it was kind of like you got your bell rung and you sucked it up and you went back in and you kept playing. And your test was if you could see the 3 fingers in front of your face, you were fine. And then about a decade or so ago, maybe a little longer than that, we started getting really, really nervous that we were causing permanent brain damage to kids following a head injury. So all of the information was coming out about chronic traumatic encephalopathy in NFL players. We didn't know what was happening to kids, and we got really conservative. And we started telling kids that they should completely rest, which meant no TV, no video games, no texting, no school, really no anything. This is to like sit in a dark room and do nothing until their symptoms were completely resolved. And we took that pendulum, and we've now kind of ended up in the middle. And we found that that management strategy is not only not helpful, but may actually be harmful. And where we've landed is intuitive, and it's a little embarrassing that it took us like 30 years to get here. But it's basically, you shouldn't do anything that makes your symptoms significantly worse. So we've moved out of the dark ages, I like to call them, of sitting in a dark room and doing nothing. So how long should kids rest? And there's no great answer, and there's no right answer for each person. But overall, we know that rest is beneficial early and less beneficial and maybe even harmful later. I just want to share with you all a couple of studies that have exemplified this paradigm. So the first randomized trial of rest was done by Danny Thomas, who's a pediatric emergency medicine physician in Milwaukee. And he took 88 concussed children and young adults and randomized them to either do the dark days of 5 days of doing nothing, or 1 to 2 days of rest, and then gradually returning to activity. And he found that the 5 days of strict rest group had more symptoms, and it took longer for their symptoms to resolve compared to the group that did 1 to 2 days of rest, and then gradually returned to activity. And since then, there have been a few additional studies that have mirrored these results. And one additional thing that Ronnie is going to address in a little bit is the idea of making it worse physiologically and also psychologically. So Mark DeFazio is a neurologist in Washington, D.C., and he coined this term activity restriction cascade, where you have a patient who has an injury, they get prescribed rest, and think about being a teenager and what are the validating things in your life, and they are all the things I just said we took away from them. So you can't use your phone, you can't watch TV, you can't go to school and see your friends, you can't play sports. They started getting more symptoms. They reported those symptoms. People prescribed additional rest, and there was this never-ending cycle of symptoms and rest. So we've tried to move away from long periods of strict rest into getting kids back into some activity earlier on. And the analogy I use when I'm describing this to families in the clinical setting, and I think that is helpful to frame this in your own brain, is it's kind of like an ankle sprain, where if you sprained your ankle, you wouldn't go and run a marathon the next day, but you also wouldn't go sit on a couch for a month until you felt nothing at all in your ankle. Your ankle would become deconditioned, and you'd end up with other problems as well. So we have 2 treatment goals when we're treating kids with concussion in our settings clinically, but also we want to extrapolate that to the camp setting. So the first, and I think these are equally important, but the first is avoiding a repeat head injury. So we really want kids out of things where they could hurt their head again. And when we're managing kids in the non-camp world, we think about things like ball sports. So a sport where a ball is being thrown around is a high risk to having a repeat head injury. At the same time, while you can exclude kids from sports, you can't exclude them from life. And there are, as Julian mentioned, a lot of activities that are non-sport related that can lead to concussion. As we're avoiding a repeat head injury, we also want to prevent deconditioning. And there are a few ways kids can become deconditioned following a concussion. So they can become cognitively deconditioned. So if they don't strain their brain at all or stress their brain at all and just sit and do nothing all day, every day for days on end, they can become cognitively deconditioned, and it can take them longer to eventually get back into activity. They can become physically deconditioned. So this is avoiding aerobic or physical activity for long periods of time after the concussion can lead to physical deconditioning. And they actually can become socially deconditioned, and this is what Mark DeFazio described in his activity restriction cascade, is if you take a kid and you keep them out of school for a month, that can have severe impacts on their social skills. And I know I'm preaching to the choir about what is beneficial of being in camp, but there are so many benefits of being in the camp setting, and one of the big ones is social interactions. So again, we want kids to have some brief rest, but we don't want them being restricted from activity for a long time. We also wanted to mention legislation as we talk about getting kids back into activity. So over the last 5 to 10 years, all 50 states in the District of Columbia have passed laws regarding to concussion and when children can return to activity. These laws apply to return to organized sports. So in the camp setting generally, these state laws would not necessarily apply from a medical legal standpoint, but I think the spirit of the law should still be held into in regard. So overall, the idea is that children are removed for at least 24 hours, and then they get clearance from an appropriate healthcare provider. And who that is different based on what state you're practicing in. But the idea is that the provider has some training and some knowledge of concussion and concussion management who's clearing a child to return to play. So I'm now going to hand it back over to Ronnie, who's going to walk you through a kind of stepwise approach to getting kids back into activity.
Okay, great, thanks. So as we talked about, we want this brief rest. So for the first 1 or 2 days, it's really just resting, not doing anything that makes your symptoms significantly worse. As Dan said, gone are the days of sitting in a dark room and doing nothing after concussion. We want them to go for a walk. We want them to be outside. We just don't want to do anything that increases their symptoms significantly. And then, really, by day 3 and day 4, we would like to try and minimize the time that they miss at camp. And what I like to say, and my phrase that I talk to parents about is aggressive observation. So we're going to be observing them and seeing how they are tolerating gradually advancing back into their everyday camp life. And so that straightforward concussion can look like this sometimes, where you have that initial brief rest, and then you start out with light or limited activities. So the idea with concussion is that you do a little bit, you take a break. You do a little bit, you take a break. So the first things they can do might be limited activities with a small group of their friends, maybe doing it for 20 minutes, 30 minutes, seeing how they feel. If they're doing well with light, limited group activities, then we could advance them to return to group activities that might be with a larger number of campers. So I love this picture that we have here because it looks like they're just roasting marshmallows over a campfire. It's nothing too strenuous. It's nothing that would hopefully be too loud or too stimulating for them, and then we can see how they feel. And then as they start to do more, as they start to tolerate more activities with their friends and other campers, we can gradually advance them back to their full activities. And what I always say is the idea with concussion management is making environmental adjustments based on deficits in their symptoms. So if you're finding that loud noises really seem to bother them or bright lights really seem to bother the camper, then we're going to do those things, but just do them in shorter stints of time. So maybe the campfire and the bright light from the fire is too much for them. So maybe they're only there for 5 or 10 minutes. They're not there for the full hour and a half that everyone else is there for. And then you can slowly and gradually advance them back into being at that campfire setting. And again, it's just scaling back on activity and that cognitive stimulation and then gradually ramping back up again. If you notice that they're at an activity and they were there for 45 minutes and that seemed to provoke a lot of symptoms, and the next time you're going to do it for maybe half the amount of time so that they're still exposed to that stimulation but for a shorter period of time. The other thing that's really important that I tell my patients is that you always have an exit strategy. So if someone is going on a group activity and the camper that's concussed starts to get symptoms, headache, nauseous, then you have a way to exit that activity and get them to a place where they can just change their environment and rest for a short period of time. And when I say resting, I don't mean laying down and going to sleep. I really just mean taking a break and changing what you were doing. So people ask me all the time, how long is this going to take to recover? And what I tell patients is that most of the kids that we see, 70 to 80% of concussions, recover in about 4 weeks. For years we would say, oh, it's about 7 to 10 days. But we know in this age group that it's about 4 weeks till they're really seeing spontaneous resolution of symptoms. And then you have this other group, this 20 to 30% of patients that get concussions that seem to last longer than 4 weeks. And what I tell people about this group is that these are the kids that are probably going to need some type of formal rehab, and usually it takes about 4 to 6 months for them to fully recover. And so my goal is always, when I meet them, is to have them in this category on the left-hand side. And I say, if we do A, B, and C and all the right things, my hope is that you stay in this category. Now, I will tell you that we can do all the right things, and they're still in that 20 to 30%, but we try very hard to try and gradually ramp them back up into their world again so that they have that spontaneous resolution of symptoms. And so the role of medications comes up all the time. And we really find that the best medicine for concussion headaches is just rest. We really try and avoid over-the-counter medications like Tylenol and Motrin for a couple reasons. One is that this is a metabolic headache. It's not like a typical headache that your child would get if they were tired or dehydrated or stressed out. This is a headache because of the metabolic demand that's happening to the brain. And most medications like Tylenol and Motrin just don't work for these kind of headaches. The other thing that happens is you get rebound headaches. So if you're giving Tylenol or Motrin around the clock for several days in a row, then as soon as that medicine wears off, they're going to have a headache again. So we really strongly discourage it. I know that sometimes the Tylenol or the Motrin can take a bit of the edge off from a headache, but it really often does not resolve those symptoms at all. And so people ask me all the time, is it really in their heads for this concussion thing? And I tell them, yes, because it's a brain injury, but also, as we talked about before, what happens inside the brain in that picture that you see on the left side of your screen is this cascade of events that set off inside your brain that causes your brain to have these symptoms after concussion. So there are these chemical changes that happen. And then you have a child that is limited in the amount of activity that they can do with their friends. They're often told to stay off of electronics. Again, as Dan mentioned earlier, not use your cell phone, not be in school. Maybe you can't go to the campfire that night, and they get to be alone and isolated. So you can imagine if you can't be with your friends, you're not feeling like you can tolerate doing your normal camp activities. It's almost like this double whammy that you have of the actual brain injury itself and then those repercussions afterwards. And so we often see a lot of side effects of mood changes and emotional ability after you have a concussion. And what I tell people is that the side effects of concussion can also increase your risk of depression. Again, you have this lifestyle change. You have cognitive changes where you're having a hard time thinking for long periods of time. You can't remember things. You're having a hard time falling asleep. You're having a hard time staying asleep. You have headaches all the time. And you really kind of have this loss of your ideal self. And the other thing that happens is that a lot of people will say to teenagers, oh, this should be better in a week or so. And when kids' symptoms last longer than a week, then they get really nervous. They feel like there's something really wrong going on with them, and their expectations are really not what is happening in their reality. And so they have these alterations in cognitive processing. They have a lack of impulse control. They have poor problem solving. They're not making good decisions at this point. They have greater emotional ability, and they also get frustrated with all the limitations that they have. So we always ask about mood. It's one of the big questions that we ask our patients every time that we see them is, how's your mood? How are you feeling? Are you feeling sad? And so there are things that we also talk about with our patients, and we let them know that we're going to be asking about this every time you see us. So it's something to always think about when you are assessing your patients at camp. Okay.
Okay, so we're going to take some time to answer some questions that we see coming in. If you have some questions, it's a great time for you to add them into the chat box at the bottom right of your screen. We are getting questions in, and so we'll start with the ones that came in over the past couple of minutes. One question coming in is about how do I know if it's just a concussion and not something worse? How does that initial assessment go at camp?
All right, and thank you so much for that question. So it may seem like we've done this a little bit out of order, where we're going to talk, or we talked about management before we talked about diagnosis, but there's a reason for that, and that we really wanted to focus this webinar on rehabilitating kids from a concussion in the camp setting rather than how to diagnose it. Following this, I do have some slides, and I'll just give you a preview here about the acute evaluation in the camp setting and how I would want you all as an emergency medicine physician to distinguish a concussion from something more serious like a bleed. So just hang tight, and we will discuss in a few minutes the initial evaluation.
Okay, and another question we have here, is it okay to start activities if symptoms are remaining?
So this is a great question, and the answer is yes. So again, we want these kids to get back into their world again. It is not realistic for them to be symptom-free in order to get back to physical activities of any kind. So absolutely, even if they're having headaches, even if they're feeling a little fatigued, if they're having sleep problems, it's okay to put them in physical activity, and this can actually make them feel better. It actually decreases the length of the amount of time that they are experiencing symptoms. But the important thing to remember is you don't want to put them in any type of activity that would put them at risk of repeat head injury. So light activities, you know, doing some arts and crafts maybe, or sitting at the campfire for a short period of time. They are not doing heavy physical exertional activity like the water slides or, you know, having potato sack races.
And the other thing that I think Ronnie touched on a little bit is that there's no one-size-fits-all for concussion rehabilitation. So we'd like to think concussion is a homogeneous disease that is one injury with one set of symptoms for everyone. That's just not true. And the more we learn about concussion, the more we learn there are several phenotypes or different manifestations of a concussion. So different activities are going to bother different kids differently, which I know makes it more complicated, but I also think kind of makes it more fun to manage. So there are some kids who can absolutely, without a significant increase in their symptoms, look at a phone or a tablet or be in places with a lot of noise, and there are some kids who that's going to make their symptoms significantly worse. A kind of rote way we've used here at CHOP that I think, or I wish one of our service medicine doctors had trademarked, is what we call the 2.1-hour rule. So if you start with your headache at a 4 out of 10 on the scale of 10, it's allowed to go up to 2 points on that 10-point scale, and that's okay. If you exceed that, then you've overexerted. And the 1-hour portion of that is if you do an activity and it takes you less than an hour to recover from it. So if you have them doing arts and crafts or whatever it may be in camp all day and they have to nap for 45 minutes to recover, that's fine. If they have to nap for more than an hour, then that means they overexerted themselves.
Okay, and we have another great question that came in here, and I know we were talking about this before the webinar got underway, is what can we do for headache management? Are there kind of restrictions there? Can they take medicine? Can they, you know, what are the options there to manage the actual pain of the headache?
So great question. Again, people ask us this all the time. And what I would say is that headaches are one of the most common symptoms after concussion. Cold compresses or cold packs are absolutely fine. And really, you know, within the first 24 hours or so, if they have a really bad headache, there's nothing wrong with giving a dose or two of Tylenol or Motrin. It's just not something that I would give on a routine basis because it's really not going to help. But it might just help just to take the edge off in the first 24 hours or so. The very best medicine, as I said, is changing your environment. So if they're doing an activity and it's provoking headache, then you want to give them a break from that, let them recover following that 2-point rule, and then get back to that activity again.
Okay, so we'll do a couple more questions before we move on here. So in the 80% who do recover within 4 weeks, what is the average recovery time within that cohort?
So it's actually about 2 to 3 weeks. So it's, well, some concussions can recover in 24 to 48 hours. The vast majority take 2 weeks to recover. So when we think about kids being in camp, and one of the other things we surveyed when we did that study was how long does a camp last? And it looks like a lot of the camps that you guys manage last for weeks on end. So I wouldn't have the expectation that a child is going to get better within 2 to 3 days. It really takes a week or two for them to fully resolve. And again, that doesn't mean they should be doing nothing for that week or two. That just may mean they're going to have some lingering symptoms for that week or two.
Okay, great. We have a question for about, let's see, about one more before we get underway here. So I think this is interesting. So the primary cause of head injury concussion at our camp is the result of campers being hit in the head by the boom of a sailboat. This is always a risk when sailing. Once symptoms resolve, okay to return to sailing, because that is, maybe perhaps like a ball. And if yes, how to avoid re-injury.
Sure. So I love this question. So again, it is absolutely okay for them to return to sailing, but the idea is to keep them out of high-risk activities. So maybe they want to get into the boat when all the other campers have gotten into the boat already, or maybe they're the first person to get into the boat so that there's not a lot of people around and not a lot of other booms around that could actually hit them. So that's one option for you. The other thing that's important when they're getting to a boat and when they're doing any type of water activity is that they are supervised by an adult of some sort. So it's, water activities are also, they're good for our campers to do, but we always want to make sure that they are monitored appropriately. So if they start to get symptoms and maybe they're not picking up on it, then there's an adult that's watching them and seeing that they just don't seem that right. So I hope that answers your question.
Okay, so we have a few more prepared slides that I want to dive into, and then we're going to come back. So I'm going to spend 2 or 3 more minutes with these prepared slides, and then we'll have another 15 minutes or so for more question and answer. So keep typing in your questions. But this is one of the questions that came up, and it is one of the important things when we're dealing with concussion, and that's when to seek higher level of care. When should you be worried about something more serious than a concussion? So when I'm seeing a kid in the emergency department, and if I were to be evaluating them outside of it, I'd use the same sort of list of symptoms that are signs of a structural injury. So these are things, if you see them, are definitely concerning enough that I would encourage evaluation by a physician outside the camp setting. So certainly a seizure following a head injury. If you have a focal neurologic deficit, so that's something like weakness or numbness in an arm or a leg, persistent inability to recognize people or places, or persistent confusion or restlessness. Ronnie did talk about that you see some of these symptoms with concussion, so there is some overlap. Where we get concerned is where you have a lot of these or they're persistent or severe, so it's a spectrum. Concussion is a type of mild traumatic brain injury, and there are moderate and severe traumatic brain injuries. So a spectrum, you may have a little bit of impaired consciousness or be a little confused, but we're really talking about significant confusion. They don't know where they are. They don't know who they are. They don't know who you are as someone who is evaluating them. Certainly someone who's either difficult to arouse or you cannot arouse at all. Someone who's having repeated vomiting, so nausea is certainly a symptom of concussion. You can have 1 or 2 episodes of vomiting, but if you have repeated vomiting over and over again, that's a sign of increased intracranial pressure, and then slurred speech is another concerning sign. We put loss of consciousness with several question marks here because that's kind of like a plus-minus to me in terms of signs of a structural injury. When we study kids who are at higher risk for having a bleed in their head after trauma, one of the features of the injury that makes them higher risk is an episode of loss of consciousness. However, about 10% of kids with with concussion will have a loss of consciousness with no bleed in their head. So what I would say is, if you have a child who has a brief loss of consciousness following a head injury and they return to their baseline quickly afterwards, they don't have any of these other warning signs, it's okay to observe them in the camp setting. The other thing I will say is, while we don't want every single child with a head injury being sent to an ER, we certainly don't want you to feel like you can't send children to the emergency department following a head injury. So everyone has their own levels of comfort and concern, and if you are concerned or worried about a head bleed, please absolutely send them to the ER. We will never fault you for sending a child to the ER who we think is okay to go home. So I'm just going to walk through kind of briefly initial steps following an injury, and I think these can apply to concussion but other injuries as well. So once a child is injured, we want their head and neck stabilized. The first thing you can ask them is what is their name, and then if they're not responding to you, you can go down a path of CPR, assessing their airway, their breathing, their circulation, which is a whole other talk. There's a series of sideline questions that I think can probably be adapted to the camp setting. They're called the Maddox questions. And there are 3 questions that give you a sign of if a child has a concussion or not. And they are, what game were we playing? What period or half is it? And who scored last in this match? Then asking about pain in the neck or pain in the arms and legs, checking for sensation, assessing movement in the limbs, and then finally removing the stabilization from the head and neck. And then one final note that I will mention, because we do get a lot of kids coming to the emergency department who the parents are seeking head imaging to diagnose a concussion. Certainly if a child has any of those features I mentioned before, head imaging may be warranted to rule out a bleed. Head imaging, as we have it now, is not useful in diagnosing concussion. So you will not see any signs on an X-ray, a CAT scan, or a run-of-the-mill MRI that will help you diagnose a concussion. This imaging is only really useful to rule out other more serious injuries. So why don't we, before we give our wrap-up slides that talk about our other resources, why don't we reopen it up to questions? And we have about 10 or so minutes to answer a few more questions. So I'm going to hand it over to Suzanne.
Yeah, so there's a question or two here about campers with developmental disabilities that I think is a really great question to address, because I know that is another layer of complexity here to managing concussions.
So this is a great question. Are the signs and symptoms the same for campers with special needs and developmental disabilities? So I will say that everybody reacts to concussion a little bit differently. Most of the patients have headache, but not every single patient has a headache. And whatever you brought into your concussion is you're going to see afterwards, meaning that if you have a kid that has ADHD, then their threshold to get attentional deficits after concussion might be lower. If you have a patient that has anxiety or emotional ability, then after concussion, their threshold to experience that anxiety or that emotional ability might be different. So you really have to take, as Dan said earlier, every single patient individually and really know what's going on with that kid. Overall, you're going to treat the same. You're going to have them rest for a day or two, limit their exposure to higher level cognitive and physical stimulation, and then gradually advance back into your world again. Some kids that have developmental disabilities that really like a structure and a schedule might actually have worse symptoms if you remove them from their typical daily schedule that they have every day. So that's something to think about when you're taking care of this patient population.
Okay, another question we wanted to address here was related to, is it a concussion anytime they get a headache? Let me see it. Is it a concussion anytime they get a headache after a head injury? So after a head impact of some sort and they have a headache, is that a concussion?
Yeah, so this gets into what is a concussion. I think this is a debated topic right now as we lack really any objective way to diagnose concussion. So there's no blood test or head imaging test that diagnoses it. I think taking the definition strictly as it is, if you had a head injury and then you have concussive-like symptoms following, that is defined as a concussion. I think what's tricky is there are kids who may hit their head and have just localized pain and may not go on to any other symptoms. So sometimes right after the injury, it's actually too soon to say if they have a concussion or not. So an approach that we often take is if a child hits their head and has some localized pain, and let's say this happens on Sunday evening at camp, is maybe remove them from activities for the evening and tomorrow or Monday morning wake up and see how they feel. And if they develop that laundry list of symptoms that Ronnie talked about before, then I would say, yes, they probably have a concussion. If they wake up and they feel fine, they probably didn't. They can go back full steam ahead. So it's tough to know, is the headache because they have concussion headache, or is it just because they bruised their skull or the skin around their skull and they have no additional concussion symptoms after?
One of the things that I would add to that, though, is that if someone had a head injury and then they have a headache afterwards and it's actually been brought to your attention as the camp nurse, then you can see how things go, as Dan said. You can assess them later on the day and see if they have a headache. If they wake up the next day and they feel fine, that is great. But what I would do is I would still instill that aggressive observation and advance them back into some non-contact, non-risk physical activity or cognitive activity and see how they do. If they do great, awesome. In my opinion, as Dan said, this whole question of is this a concussion or not, I think that in simplest terms, if there's a head injury, some type of injury that causes their brain to shake and they have symptoms afterwards, it's a concussion. But if symptoms resolve and they're able to get back into their world again the next day, then great, and we don't have too many concerns about those kids.
So one of our questions is related to, are there sort of symptoms that are red flags for restricting certain activities?
Yeah, so this is another one that's evolving as we try to learn more about concussion. So we're really awful at predicting what symptoms are correlated with having a longer recovery. We used to think that someone who has more symptoms up front should be restricted from more activity because they're going to have a worse injury, and that hasn't really borne out. So it's tough to know early on following a head injury who's going to be someone who takes a month to recover and who's going to get better in a week. I will say that there are specific things that might make us a little hesitant to get kids back into activity immediately. And those would be, I think, so if you're looking at the child who's super symptomatic with eye tracking, then I wouldn't want them to avoid eye tracking activities. If you have a child who's very sensitive to light or noise, I'd want them in a more quiet or sheltered place afterwards. So that's the kind of tailored management you would give.
Another question here is related to nausea, and if the child is nauseous, can you treat the nausea with any kind of medications?
So another thing we're studying, and I don't know what ability you have in the camp setting to give out things like antiemetics like Zofran. If you have that, it actually turns out to not be incredibly useful following a concussion. There have been a couple of studies that show there's not any direct benefit in reducing post-concussive nausea. So as Ronnie said, right now the best thing we have is the removal of exacerbating activities. We hope as time goes on we get more specific medications. One of the things that we have found to be related to post-concussive nausea is kids who get dehydrated, so making sure they're adequately hydrated is a great first line. But unfortunately, there's not a great anti-emetic or anti-nausea medication for concussion.
All right, so moving on to so talking about a child that you described who had the injury Sunday night, would you have them stay in the health center that night? No more waking up every few hours like we used to hear?
Yeah, and I will forgive whoever wrote this in saying they're old. I can't imagine you're that old. But so the old thinking of keeping a child awake after a head injury was that if they have a head bleed and you allow them to fall asleep, they won't wake up. We have debunked that, I think, with a lot of our activity. So what I would say is if you have a child who has a head injury and you have any of those warning signs or symptoms, then have them be evaluated by a physician. If they don't, they have a headache, mild dizziness, mild balance problems, but don't have the warning signs and symptoms, they're allowed to sleep however they like. They're actually going to be more sleepy than normal because that's part of the concussion. So it's fine to have them go to sleep. We'd actually encourage them to go to sleep afterwards.
Would you guys recommend any specific assessment tools or forms to help with the initial diagnosis or the initial assessment?
So there are some great tools called the SCAT, S-C-A-T, which stands for the Sport Concussion Assessment Tool, and it's actually now in its 5th version. So there's the SCAT-5 that's out there that you can Google and print out that PDF. It's available and free to everyone, and that has a great, really quick and brief symptom assessment, injury assessment, some brief physical exam findings that you can do, as well as some really short cognitive questions. So it's a great tool to use.
And one other tool that's available, the CDC, this is also free on their website, has an assessment, and someone actually popped in that they use that symptom question or checklist, and that's great. Because right now we really rely mainly on symptoms. There are some specialized physical exam maneuvers that we do in the sports medicine world that I think are beyond the scope of what I would expect anyone to do in the camp setting. So I think that symptom checklist in combination with your injury mechanism is a great start off for assessing, diagnosing, and then managing and following those symptoms as they evolve over the next few days.
Okay, well, we have time. There's one more question here we haven't had a chance to address, and that was, flip up, there we go. Is it common with concussion to not immediately recall the event, or is that an indicator of something more serious?
I think that this is something that can happen, but they really should have a pretty good idea of what's going on or what just happened to them. Those Maddox questions that Dan mentioned earlier about asking what venue are you at, what were we just doing, what activity we were doing, just because they do well on those answers and they answer all those questions correctly doesn't mean that they don't have a concussion. But that's a good first line of assessment of questions to actually ask your patient. They certainly, it can happen that they might not immediately remember what just happened to them, but I would suspect that as the dust settles, that they start to actually remember their events and what caused that head injury. The ones that, the mechanisms of injury that the patients don't remember, I tend to think that those are a little bit a higher level, more of a moderate or severe traumatic brain injury.
Okay, so how often should an individual be checked before a severe concussion is ruled out? So do we check in the health center every 15 minutes for an hour, or when do we do that?
So what I'd usually say is the signs of a, not just severe concussion, but signs of a bleed that would require a child to leave camp and be emergently evaluated generally appear within 2 to 4 hours following the injury. There's actually a great article that was published almost a decade ago that evaluates children at high risk following a head injury who need CAT scan in the ER. And it was found that if children met low-risk criteria within 2 to 4 hours, they did not go on to have a head bleed. So I think you can feel safe after that 2 to 4 hour window of saying they can, go about whatever activities you'd like from a resting at camp standpoint. In terms of when to absolutely send someone to an emergency department, I, again, am bringing up the slide of signs of a structural injury. So I would say if a child has one of these, they should be removed, not just from their activity, but from the camp setting. And part of this, and this is what makes it tricky, is it's always a judgment call. So again, I would encourage you to feel empowered to seek higher levels of care. So if you have a child with a head injury, you're wondering if they should seek emergent care or not, don't feel scared or bashful about having them be evaluated in an emergency department. We'd always rather see someone who we can say can leave and be sent home, rather than have someone who needed to be there not show up.
Okay, well, we are approaching the end of our hour here. I want to thank Ronnie and Dan for today's discussion on managing concussions at summer camp. We would like to invite participants, we move beyond that. As we come, so please note that we will send an email that will automatically be generated to all registrants, which will provide links to all the resources we mentioned today. And a little later, we'll send a link to the recorded webinar in case you have colleagues who couldn't attend today, or that you want to share the recording with your colleagues.
Sorry, Samantha, I just want to jump in and point out that our website, our CHOP Concussion website, which is chop.edu/concussion, has a lot of wonderful resources on it, so I'd encourage you to browse that at your leisure. There's actually a specific section on managing concussion in the summer camp setting. We also have on this website information for both providers and for patients and families if you want to share some resources with your families in addition to any other camp providers.
Thank you, Dan. I appreciate that. So I want to thank you all for participating. This is a really terrific and engaged group of participants. We really appreciate all that you do to protect the health, to protect and enrich the lives of children. We hope this webinar was useful and actionable for you. And we also want to thank our presenters, Ronnie and Dan. Thank you so much. Thanks and goodbye, and have a great week.